Hello, Professor Kalemkerian. This is a great honor to have an interview with you.
Thank you, Nune. Thank you for the invitation.
Today we will do a small cell lung cancer, and my first question will be, what distinguishes small cell lung cancer from other types of lung cancer, particularly non-small cell lung cancer?
Well, the main thing about small cell lung cancer is that it is a very aggressive disease. It grows quickly, it spreads quickly with early metastatic potential. The other thing that separates it a little bit is the neuroendocrine characteristics that it has, which mainly from a clinical standpoint lead to paraneoplastic syndromes, both your endocrine paraneoplastic syndromes like SIADH, syndrome of inappropriate ADH secretion, and neurologic paraneoplastic syndromes that can have a significant impact on the patient's quality of life.
Thank you very much. How does the biology of small cell lung cancer differ from other lung cancers?
Well, it's a very smoking-related disease. So the vast majority of people, 98, 99%, are big-time former smokers, cigarette smokers. So it has a very high tumor mutational burden, which means there are a lot of abnormalities within the tumor. And what that leads to is a lot of potential resistance pathways along with those mutations that can lead to treatment resistance, which is a huge problem. It's almost ubiquitous that small cell lung cancers have P53 mutations and RB mutations in them. These are tumor suppressor genes, and we are not very good at targeting tumor suppressor genes when it comes to treatment. Unlike non-small cell lung cancers, where the abnormalities we have found to treat are proto-oncogenes that are targetable because they're gain of function and you're blocking of function. The tumor suppressor genes are much more difficult because they're loss of function, and it's hard to replace function when you're thinking about therapy. The other thing more recently about the biology is that small cell lung cancers almost uniformly express DLL3, which becomes important when we start talking about newer treatments.
What do you think was the first event humanity understood small cell lung cancer is a global clinical and public health burden, and why?
Why? Because it's even though when you look at lung cancers, it accounts for about 15% of all lung cancers. But when you look globally, that becomes a very large number of patients with small cell lung cancer. And it has an extremely high mortality rate, despite some of the advances we've had recently. Still a very bad cancer, and a very smoking-related cancer, like I mentioned earlier. So it is a preventable disease for the most part. And because of that, I think it deserves a lot more attention from the public health sector, as do all smoking-related cancers and diseases, because they are clearly preventable if we have resolve to make the changes in society that need to be made.
The literature indicates that the incidence of small cell lung cancer is now approximately equal between males and females, but it was previously more common in males. What factors do you think we have contributed to this shift?
I think the main factor is smoking patterns, and I know best what's going on in the United States. And in the United States, when the Surgeon General report came out in the mid-'60s saying that smoking was related to lung cancer, which most people already knew, but when it became publicly well advertised, the male smoking rates started dropping fairly quickly. Female smoking rates did not. They continued to rise, probably because of increased advertising and athletic support and those kind of things that led to more women smoking. So the rates in women continued to rise for a while and then eventually plateaued and now are coming down. But that carries through for small cell because it is a very smoking-related disease. So over time, as the men had a much sharper decline, the incidence in men started to decline much more quickly than that of women, where they continued to smoke more. So I think that's purely why we're seeing that. Where now we just recently did an analysis of the SEER database, and the last several years, actually women are more common in small cell lung cancer. More women have small cell lung cancer in the United States than men.
Do you think low-dose CT will contribute to the early detection of small cell lung cancer as a regular screening procedure?
No. And some data from the NLST, the U.S. randomized study that looked at um, screening with low-dose CT scan versus chest X-ray in the United States, and demonstrated an improvement in lung cancer specific survival, as well mortality, lung cancer specific mortality, and also an overall mortality with the use of low dose CT scan, demonstrated that for non-small cell lung cancer. It did not appear to have an impact on small cell lung cancer. And the reason for that is likely that it is too aggressive of a disease. It is not uncommon that I see patients in clinic who have had a CT scan, chest X-ray 3 months ago, 6 months ago, and it was completely normal. Even CT scans, completely normal. And now they come in 3 months later with a 5-centimeter mass at the hilum of the left lung and massive mediastinal lymph nodes. So small cell lung cancer appears to be too aggressive to pick up on an annual CT scan.
Thank you. Have we had any breakthroughs over the last decades regarding small cell lung cancer treatment and prognosis?
I don't know if I would call them breakthroughs. We've had some advances. Breakthroughs implies a major benefit. I think we've had advances with modest benefits in this disease. Obviously improvements in radiation technology and techniques have made an impact, I think. And then we have the integration of immune checkpoint inhibitors into both limited stage now and extensive stage disease that have had some impact on hopefully overall survival. And we'll talk a little bit more about those down the line. And then we have the first targeted therapy that was approved last year in the United States for small cell lung cancer, tarlatumab. It's a bispecific T-cell engager that binds to DLL3 and also to T-cells as an immunotherapeutic approach for relapse non-small cell lung cancer with a promising duration of benefit in some small group of people. So yes, we've made some advances, not nearly as much as in some other diseases, including non-small cell lung cancer, but they're bricks in the wall that we're starting to make some movement.
Recently, you published the ASCO Ontario Health Guideline, which is the same as Cancer Care Ontario. What do you consider to be the main highlight and novel contribution of this paper?
Yeah, so we really summarized the recent advances that I just mentioned. So really focusing on the integration of immune checkpoint inhibitors into extensive stage small cell lung cancer treatment. Most recently, we do have an update that is coming out in hopefully a couple of months here that is integrating checkpoint inhibitors into the treatment of limited stage small cell lung cancer based on the Adriatic trial. And then looking at the relapse disease, in the last couple of years, we've had lurbinectadine, a chemotherapeutic agent, added to the armamentarium for relapsed patients. And most recently, coming out in this update as well, is going to be the use of tarlatumab as another option for people with relapsed small cell lung cancer.
When performing immunohistochemistry on small biopsy samples with crushed or necrotic cells, which markers do you think are must done to diagnose small cell lung cancer?
Yeah, so we'd be looking at the neuroendocrine markers primarily. Now, I'm not a pathologist. I will have to state that. But we look for synaptophysin, chromogranin, INSM1, CD56, which is also known as NCAM, neuron cell adhesion molecule. And then also looking at the, those are all would be expected to be positive. Those small cells don't express all of them. Very few small cells will express all of them. Usually they'll express 1 or 2 neuroendocrine markers. And then you want to see the negatives. So small cells are small blue cells. which can sometimes look sort of like abnormal lymphocytes or lymphomas. And I've seen confusions between those, and I've seen lawsuits because of confusions between those two. So you want negative lymphoma markers such as CD45 or CALA to be negative in those tumors as well. Sometimes if they're very poorly differentiated, you might need to do negative markers for poorly differentiated adenos or squames. But usually the histology can differentiate those things.
What are the challenges in differentiating small cell lung cancer from large cell neuroendocrine cancer using immunohistochemistry?
My understanding is that it's primarily a histological differentiation. Again, one is small cell, one is large cell, right? Though you do have these things that are somewhat in between these diseases. There used to be something called intermediate cell small cell lung cancer. That is kind of an in-between characteristics. So it's really a histologic, cytologic diagnosis. Immunohistochemistry is going to be very similar between those two as far as the neuroendocrine markers that might have one or two positivities. Again, because these are poorly differentiated neuroendocrine tumors, they don't tend to have overwhelming neuroendocrine characteristics, but have some. And they don't have the neuroendocrine architecture that you see with, say, carcinoid tumors.
Can you discuss the role of CT versus PET-CT in diagnosing small cell lung cancer?
Yeah, so in patients with CT evidence of limited stage small cell lung cancer. So you do CT scans, chest, abdomen, pelvis, and all you're seeing is a hilar mass and mediastinal adenopathy, nothing in the pelvis, nothing in the bones. In those individuals, when PET scan is done, about 15% of them will have findings that upstage them to extensive stage disease rather than limited stage disease. So in that situation, I think PET scan can be very helpful. PET scan can also be helpful in those limited stage patients. Even if they don't have distant metastases, it can be very helpful in planning radiation to determine the extent of lymph node involvement within the chest and to include all of that disease within the radiation field. So in people with conventional staging, CT scans showing limited stage, I think PET scan can be very helpful in determining treatment. In people with extensive stage disease, based on CAT scans, based on biopsy, so somebody has multiple mets, bones, liver, adrenals, you do a biopsy of the liver and it's small cell lung cancer and they have bulky disease in their chest, I don't think you need a PET scan. I think that's a waste of resources because you already know that it's extensive stage disease and the PET scan is not going to help you do anything differently. You should also always get brain scans on people, no matter how early stage their cancer looks with small cell, because the rate of asymptomatic brain metastases is quite high.
Do you prefer the Veterans Administration Lung Study Group two-stage classification or the American Joint Committee on Cancer classification two-stage small cell patients, and why?
Yeah, so the TNM classification or the AJCC or UICC classification can be used to stage small cell lung cancer. It doesn't work quite as well in small cell as it does in non-small cell for prognostic purposes, mainly because the main database that was used to develop the staging guideline was from non-small cell lung cancer, but it can be used. I prefer the VA system. VA system is the extensive stage, limited stage, two-stage system. It's simpler. But the main reason I prefer it is because almost all of the clinical trial information we have that guides our treatment decision-making was done utilizing the two-stage system. So it's the cleanest way to know what to do for your patients. Now, that said, quite honestly, the stage 1, 2, and 3 lines up very, very, very well with the limited stage small cell lung cancer. So there's a little bit of fuzziness around stage 3 on whether it's limited or extensive in some situations. But I do prefer the VA system just because that's where most of our data has been derived from.
Limited stage small cell lung cancer is diagnosed in only 5% of cases. Why is early detection so difficult?
So I'll have to correct you a little bit on that. So limited stage is diagnosed in about nowadays 25% of patients. The less than 5% or fewer than 5% of people are diagnosed with stage 1 small cell lung cancer. And this is the one situation where we do utilize the TNM classification routinely, is in identifying those patients with stage 1A through stage 2A tumors. And the reason for that is that the recommended treatment for those patients with small cell is surgical resection followed by adjuvant chemotherapy. It is rare. The vast majority of people with limited stage small cell have bulky mediastinal lymph nodes. So finding someone with a solitary lung nodule without any hilar or mediastinal lymph nodes is less than 5% of people with small cell lung cancer. Why is that? I think because it's an aggressive disease, because it has early metastatic potential, both into the lymph nodes as well as in distant metastases. So it's just hard to pick up on any kind of screening exam.
How frequently do you see early stage like T1, 2A, and 0 small cell lung cancer in your practice as stage 1 disease incidence increased during the previous years?
Right. So as we just mentioned, these early stage patients who might be surgically amenable, it's fewer than 5% of people. At our institution, we see 1 or 2 a year coming in. And mainly those are found on people who had a solitary lung nodule, big time smoking history. It was growing. It was PET positive. The surgeons went in, they took it out. There were no lymph nodes involved, and yet it was a small cell lung cancer. And we get those presented at our tumor board, and then we recommend usually adjuvant chemotherapy after that. So if you see those patients ahead of time before surgical resection, then all of them should have good mediastinal staging. And we're really talking about tumors that are 5 centimeters or less, solitary lung nodules with no evidence of mediastinal or hilar lymph nodes. So in those situations, I do favor a surgical approach followed by adjuvant chemotherapy. And with that approach, recent reports have shown upwards of 60% long-term survival, 40 to 60% long-term survival with that approach. That doesn't mean that you can't do chemoradiation for them. We don't have a lot of good comparative data for chemoradiation, but mainly I favor a surgery if you're 5 centimeters or less, so T1A through T2B, N0 tumors. If there's any lymph node involvement found on endobronchial ultrasonography and biopsy or on imaging, PET scans, or mediastinoscopy, then I would definitely favor a chemoradiation approach rather than surgery.
What is your approach to the surgical treatment of patients with limited stage small cell lung cancer in rigorously staged cases with localized small cell lung cancer? Do you favor surgery followed by adjuvant chemotherapy versus chemoradiotherapy? I guess we already touched this question.
Yeah, we already touched on it that, yep, surgery is recommended. Yeah, the important part of that question was the rigorous mediastinal staging to make sure they don't have lymph nodes.
Do you prefer cisplatin over carboplatin for both limited stage and advanced stage small cell lung cancer?
I somewhat favor cisplatin for limited stage small cell lung cancer, and the main reason for that is the vast majority of the data has been with cisplatin in that situation. For extensive stage small cell lung cancer, I favor carboplatin. I think it is a better palliative drug. I don't think cisplatin is a good palliative drug because of its administration issues and because of its non-hematologic toxicity issues. With that said, there has actually only been one randomized study that compared cisplatin etoposide to carboplatin etoposide directly in small cell lung cancer. It included both limited and extensive stage patients. It was not the biggest trial in the world. And in that trial, they looked the same, cisplatin and carboplatin, both in limited and extensive. There also was a meta-analysis that compared 4 trials. Not all of them used kind of equivalent regimens. As I mentioned, only one used platinum and etoposide as their base regimen. But in comparing a cis regimen to a carbo regimen, this meta-analysis also showed equivalence of cisplatin and carboplatin. So in my heart of hearts, I believe that they're equivalent. Because the preponderance of data in limited stage is with cis, I somewhat favor that, though I very freely use carboplatin if people have any contraindications or intolerance to cisplatin. But in the extensive stage setting, I definitely much favor carboplatin as a much more tolerable drug.
Do you consider skipping prophylactic cranial irradiation in limited stage small cell lung cancer among certain populations?
So in limited stage small cell, meta-analysis back now 25 years ago did demonstrate an improvement in overall survival at 3 years of about 5% with the use of prophylactic cranial radiation in people who'd had good response to chemoradiotherapy. So yes, I do favor PCI in people who are good candidates for PCI, which is what the question is. And if people are over 70 years old or so, I start to back off my recommendation for PCI, mainly because of increased neurocognitive difficulties that can arise. People who have pre-existing neurocognitive difficulties, I think PCI probably is something we can hold off on. The alternative to prophylactic cranial radiation is MRI surveillance. In extensive stage disease, MRI surveillance has been shown to be probably at least as good as PCI and is what I favor in extensive stage. And the studies are ongoing looking at PCI versus MRI surveillance in limited stage small cell lung cancer. So we look forward to seeing what those are, to see whether or not we need to expose all patients to whole brain radiation with PCI, or if we can just focus on those people who have relapse and find them early with MRI surveillance closely and treat them at that time.
This year, the ASCO conference presented interim analysis results from the Adriatic trial showing promising data on definitive durvalumab compared to placebo following concurrent chemotherapy. What are your thoughts on these results? Do you believe the final analysis will yield similar positive outcomes?
Yeah, so the Adriatic trial utilized maintenance or consolidation durvalumab for a couple of years after chemoradiotherapy for people with limited stage small cell lung cancer who had not progressed. And this study did demonstrate a fairly large improvement in median overall survival, about 20-month improvement in median overall survival. When we look at 2-year and 3-year overall survival rates, the benefit was in about the 10% range of benefit for overall survival at 2 and 3 years. So does look like there is a real benefit. And if we're looking at 3-year overall survival in limited stage small cell, historically that has been equated to a relative cure rate because the disease tends to recur quickly when it does. So it does look like this 10% of people may have a big benefit from immunotherapy. That fits very well with the data that we saw in extensive stage small cell lung cancer, with about 10% of people benefiting from atezolizumab or durvalumab. And it also fits pretty well with what we've seen in other situations in small cell lung cancer, like relapse disease, where about 10% of people benefited from immunotherapy. So I do think it's a real benefit for a small group of people. And our next goal, which I think we'll talk about later, is how do we identify who those people are who are benefiting from it? So yes, I do believe that it is going to be a real finding that is going to hold up over time. Now that said, at ASTRO this year, data was presented from the NRG LU005 study, looking at using atezolizumab concurrently with chemoradiotherapy and also then as consolidation afterwards in people with limited stage small cell. And this was a negative trial as far as the data that was presented thus far, where the atezolizumab did not appear to benefit patients. This is fairly similar to what was seen in the Pacific trials that have been presented so far in non-small cell, where using immunotherapy, durvalumab as consolidation had a benefit in the Pacific trial, but in the Pacific 2 trial, where they used durvalumab concurrently with chemoradiation, there was no benefit. So I'm not sure what's going on there. There's some thought that, well, when you give immunotherapy during radiation, radiation is very good at killing off lymphocytes and immune cells. So maybe there's going to be no benefit there. Why in that situation would subsequently the consolidation therapy not be beneficial? I can't quite explain as well. So there is a little bit of competing data that is coming out. So we're going to have to look at the entirety of the data. There are several other trials that are pending in this limited stage space with immunotherapy. And I think we're going to have to look at the way all the trials were done and the overall results longer term in order to know exactly how immunotherapy is going to integrate into the treatment of limited stage small cell.
The Adriatic trial includes another experimental arm comparing definitive durvalumab plus tremelimumab to placebo, but we don't yet have data on this investigation. Do you believe that the combination between PD-L1 inhibitors with CTLA-4 inhibitors will yield better outcomes?
No, I don't believe it will. And the reason for that is being a little bit of a cynic. I do believe there's a reason why we haven't seen the data, right? The data is probably not very promising. And we also have other data from other situations in small cell lung cancer. We do have data from the Caspian trial in extensive stage small cell lung cancer where the durvalumab, tremelimumab did not look like it was any more beneficial than durvalumab alone. We do have data with ipilimumab in patients with relapse disease, where it did not look like there was any real benefit to adding ipilimumab to nivolumab. So I don't have a lot of expectation that the addition of a CTLA-4 inhibitor is going to be beneficial in addition to a PD-L1 inhibitor in small cell lung cancer.
ESMO 2024 Adriatic trial data showed grade 3-4 adverse events in 28.4% of patients in the durvalumab groups and 29.6% in the placebo groups for those who had received PCI within 28 days prior to immunotherapy. This suggests that prior PCI did not increase toxicity with subsequent immune checkpoint inhibitor treatment. Do you anticipate this outcome?
I mean, I don't think it's surprising. I think that a lot of trials have been done looking at immunotherapy plus radiotherapy. And I don't think we've seen a substantial increase in additive or synergistic toxicities in those situations. So I don't think from the toxicity standpoint, it's too surprising. I don't think it's something that should be done on a regular basis. I think if we're going to do PCI for limited stage patients and then do consolidation durvalumab, you should do the PCI first, get it done with, make sure people are doing okay, and then get going with the immunotherapy. The other thing I'll mention with those numbers, that you did mention that the numbers looked similar between durvalumab and placebo. That's something that always bothers me. I just believe that one drug is more toxic than no drugs, and two drugs are more toxic than one drug. And a lot of studies now are showing that adding immunotherapy to this, that, or the other thing does not increase toxicity. That can't possibly be true. I've used immunotherapy in over 500 patients at this time, and it is toxic. So it does add toxicity. So these trials that are saying it doesn't, I just don't get it on how they're coming up with those numbers. They're good drugs. They work for some people, but we have to be honest about it. They do have side effects.
First-line chemotherapy for advanced small cell lung cancer has remained unchanged for many years. In your opinion, what are the reasons for this lack of progress? Have we fully optimized chemotherapy options for this diagnosis, or could we do more?
Yeah, so I'm one of those people who has made a career out of doing negative trials in small cell lung cancer, and it's not a terribly great legacy. But it is the fact that we have tried many targeted therapies, we have tried many chemotherapy approaches, and nothing seems to have broken through the carboplatin and etoposide or cisplatin and etoposide. And even if you look back at the alkylator regimens, well, platinum etoposide was not a whole heck of a lot better than the cytoxan, adriamycin, and vincristine type of regimens either. So we haven't made a lot of progress systemically. Even when we look back at the Empower trial and the Caspian trial, in extensive stage small cell with the addition of immunotherapy, the benefit is relatively modest, right? It's about 10% of people seeming to benefit from the treatment. So we haven't made a lot of progress. Why is that? As I mentioned very much earlier here, very high tumor mutational burden, lots of abnormalities going on in these cells, lots of bypass pathways that can get around any kind of drug sensitivity to lead to resistance. It's a highly mutable cancer, so it can easily develop acquired resistance. And I also think that there is some population of progenitor cells. Whether you want to call them stem cells or progenitor cells, whatever, there's some group of cells that we're not killing off, right? Platinum etoposide can kill off 99.999% of small cell lung cancers. We see dramatic responses in these people fairly briskly. And yet there's some group of cells that we're not getting that has inherent resistance that then repopulates and recapitulates the entire tumor to eventually, unfortunately, cause the patient's death with much more resistance in those differentiated cells at that point. So lots of chemotherapeutic strategies have failed. 3 drugs instead of 2 drugs, dose-dense 4-drug regimens, even, I dare say, bone marrow transplantation wasn't a very good experiment. Maintenance therapy, consolidation therapy, early second-line therapy, lots of things have been tried and haven't worked. So I don't believe that further chemotherapeutic approaches, cytotoxic chemotherapeutic approaches, are going to be terribly useful in this situation. Even targeted therapies, because of the high tumor mutational burden in these tumors, I think individualized targeted therapies, it's going to be difficult to find one that's going to have a major impact on a large number of patients.
For advanced small cell lung cancer patients with an ECOG performance status 2-3, would you recommend pursuing active cancer treatment or focusing on end-of-life care? What factors do you consider when balancing treatment benefits with quality of life in these cases?
Yeah, so small cell lung cancer is one of the few cancers in which people with fairly poor performance status do have the potential to have substantial benefit from our standard treatments. So performance status 2 is not even really much of a question. Yes, we treat them aggressively because you do get brisk responses. We're dealing with an extensive stage disease with standard chemotherapy or chemoimmuno. You're dealing with about 70% response rates. So people do have good shrinkage of cancer, and good relief of symptom burden. So you can get an improvement in quality of life in the majority of patients, and frequently without even hitting them that hard. So people who come in are hospitalized with small cell performance status 3 and even performance status 4. So even people say who are on a ventilator because of the small cell lung cancer, say obstructing an airway, you can get very brisk responses and get them better. The problem is the long-term survival, right? The short-term improvement is very achievable, and it's frequently achievable without really hitting them too hard, because it is such a sensitive tumor to chemotherapy. So initially, for people who are performance status 3 or even 4, we would do carboplatin and etoposide. If their performance status is poor because of the small cell lung cancer. If the performance status is poor because they've had numerous strokes and heart failure and everything else, well, that's not going to get better with chemotherapy, and that's a different situation. But if it's due to the small cell, then hitting them with carboplatin, etoposide at reduced doses sometimes in order to avoid neutropenic complications or other thrombocytopenic complications is very doable. In order to get them going in the right direction, to get improvements without causing excessive complications for those individuals. And yes, the majority of people I've treated in that way have gotten better and gotten out of the hospital in order to get subsequent therapy in our outpatient setting.
Do you remember your first small cell lung cancer patient receiving immunotherapy? What was the outcome?
Yeah, I actually do. I remember her very well. She was on a clinical trial. We had an investigator-initiated clinical trial with maintenance pembrolizumab in extensive-stage small cell lung cancer. And this woman was extraordinarily anxious, extraordinarily worried about her outcome. When we first met her, she enrolled on the trial. We gave her platinum etoposide. She had a very good response to that. And then we started her on maintenance pembrolizumab as part of the trial, and she did very, very well. She had a complete response. Disease went away about 5.5 years later, and she got the treatment for 2 years, and then we stopped. And about 5.5 years after her diagnosis, she was completely disease-free of small cell, but then she developed some lesions in her brain. And long story short, these lesions ended up being glioblastoma and not small cell. And she did eventually, about 6 months, 9 months later, she did die, unfortunately, from the glioblastoma, but she never had a recurrence of her small cell lung cancer. So I remember her very well. Now, that's not the common situation. In that trial, we had about 10% of people who got out beyond a year with the maintenance pembrolizumab. And that, I think, just highlights the fact that immunotherapy does have a benefit for a small group of small cell lung cancer patients. Small cell lung cancer does not express much PD-L1, which is probably why PD-L1 antagonists don't work that well. Fewer than 20% of people have any PD-L1 expression. So they also frequently don't have MHC class 1 molecules expression, so they're not presenting antigens terribly well. So immunotherapy is beneficial for some people, but not a lot in small cell lung cancer.
What is the acceptable duration of the disease-free interval after the first platinum doublet treatment, and at which point it would be appropriate to consider rechallenging with the same regimen upon relapse?
Yeah, so there's some disagreement about this now in the literature and in guidelines. So generally, if somebody has a chemotherapy-free interval of more than 6 months, I consider utilizing carboplatin etoposide again, re-inducing them, if you will, with the chemotherapy. And in that situation, you got about a 40% response rate. There is some data that says there's benefit to doing repeat induction with combination chemo with people who have a chemo-free interval of more than 3 months. those studies have shown a improved response rate and improved progression-free survival, but no improvement in overall survival with that approach versus single-agent therapy. So generally, I do more than 6 months. Some people would argue for more than 3 months of a chemo-free interval. If people are on immunotherapy at the time of their relapse, I don't continue the immunotherapy when I reinitiate chemo. I believe that that's a failure of the immunotherapy in that situation. So, yeah, I generally use 6 months. Some people can argue for 3 months to reinitiate combination chemo.
Are there any promising biomarkers for predicting response to immunotherapy in advanced small cell lung cancer setting?
Right, and that's what we discussed. And the answer is yes, there are promising biomarkers. There's nothing that's ready for prime time yet, so nothing that's clinically validated at this point. One of the most exciting, I think, advances in small cell has been an understanding of the biology. Regular NGS testing has not been shown to really classify small cells terribly well or identify good targets in the disease. But several groups, Sloan Kettering, MD Anderson, have identified subsets of small cell lung cancer based on transcriptional expression of transcriptional factors. So really immunohistochemical expression of different factors. And one of these categories, they've come up with about 4 subtypes of small cell lung cancer, and one of them occurs in about 10% of small cell patients. It's termed SCLC, I for inflammatory or immune subtype. And this is one that has expression of many mediators suggesting a immune sensitive phenotype. So it's got the mediators that would enhance immunoreactivity in the tumor. And in a secondary analysis of the EMPOWER trial with atezolizumab in extensive stage small cell lung cancer, they do seem to show that the patients with this SCLC-I phenotype do have a better response to immunotherapy, that those are the patients who seem to be benefiting. And that 10% number kind of lines up quite well with the data as well. So there's something promising there. Whether it'll pan out, we'll see over time. So ongoing studies are being done. But just like in every other disease, it's been challenging to come up with good biomarkers for immunotherapy, right, that are predictive. We've all seen people who have PD-L1s of 100% who don't respond to immunotherapy, and people with PD-L1 scores of 0 who do respond. So we do need better biomarkers.
Do you think that molecular profiling for extensive stage small cell lung cancer patients may be useful among never smokers or light smokers?
I'm going to buck the trend here and say probably not. As I mentioned, NGS has not really demonstrated useful targets in small cell lung cancer at this point. And part of that is many of the targets, like we mentioned earlier, P53RB or tumor suppressors that we don't know how to target well, might be good for selection for patients for clinical trials in order for us to learn how to target those things. But even when we look at the non-smokers, and I will say non-smokers are rare in small cell lung cancer. I have seen 4 or 5 non-smokers in 35 years of doing this with small cell lung cancer. And 2 of those people were HIV positive patients. So it's pretty uncommon to see a non-smoker with small cell. But even when we're saying, well, maybe they had a transformed EGFR mutant non-small cell that transformed the small cell, well, we know that the small cell component of those diseases is not sensitive to EGFR inhibitors, right? They generally transform while they're on the EGFR inhibitor and develop growing small cell lung cancers. And even though you might find the mutation in, say, an EGFR mutation in the small cell lung cancer cells, it appears that it's no longer producing protein. And that you don't get the protein expression on those cells. So you're not going to have benefit with an EGFR antagonist. in those patients. And we've all borne that out in treating these people. So I don't think it's terribly helpful. Would I fault somebody for doing it? No. Right? I mean, more information, sometimes the better for clinical trials enrollment and other potential reasons, but I don't think it's going to be broadly helpful.
Are there any specific treatment considerations for the patients transformed into small cell from non-small cell with an oncogenic driver?
Oh, that's a good question because there is more to add there. So, in people who've had EGFR mutant adenocarcinoma, that then are treated with an EGFR inhibitor and transformed to small cell, one thing I've learned, and again, these are not common. I have treated 3 or 4 people in this situation, and that's it. And I see a large number of EGFR mutant patients. But what I've learned is that even though you have a tumor that's growing, say, in the pancreas, and you biopsy it and it's small cell lung cancer, and they have numerous other metastases elsewhere, that the other metastases, the other sites of disease, are not necessarily transforming the small cell. So this person probably still does have some adenocarcinoma with EGFR mutation that may still be sensitive to the EGFR inhibitor. And I've had a couple of patients where I treated them with platinum etoposide, the small cell shrunk, and I had stopped the osimertinib, and all the other disease started growing. So my standard approach now is that I will continue with the osimertinib in order to control the other disease out there that has not transformed, and I will use small cell treatment with carboplatin and etoposide to treat the small cell component. So I will use both the small cell treatment and the EGFR targeted therapy together in these people going forward.
And what about immunotherapy? Would you like, as a maintenance for the small cell component, at least add immuno with EGFR, considering the toxicities and other things?
Yeah, that one I have a little harder time with, especially because of the potential toxicities of using a TKI along with immunotherapy. With the EGFR TKI specifically, pneumonitis and hepatitis have been shown. So I have not used immunotherapy in those individuals, and I don't recommend it.
What is your first-line strategy for asymptomatic advanced small cell lung cancer with brain mets? Do you prefer upfront or versus delayed whole brain RT?
Yeah, so it depends on their symptomatic burden, right? So somebody has, you do an MRI of the head and they have 3 to 5 centimeter nodules in their brain with minimal edema, and they're asymptomatic. Well, then generally I would do systemic therapy first. And most people with brain metastases with small cell lung cancer do have responses in the brain with platinum and etoposide. So I would do, for an asymptomatic patient, I would do chemotherapy first and do close MRI surveillance, repeating the MRI scans. If we see any evidence of progression, then you can go to radiotherapy. So if they're symptomatic, then it depends on the degree of symptoms, right? Both systemically, which most of these people have high symptom burden systemically as well, and their neurologic symptoms. Frequently, in those people who have symptoms diffusely, and we actually have a woman in the hospital right now who's in this situation. We did do chemotherapy in the hospital. We gave her a first cycle of chemo, and now in the next week we're planning on getting the whole brain radiation therapy going, and then pick up with the chemotherapy in 3 or 4 weeks to do her second cycle. So we're kind of sandwiching the whole brain in there. If somebody does not have a lot of symptoms systemically, but they have symptomatic brain mets, then yes, doing the whole brain radiotherapy first would make the most sense. So it depends on the patient and the individual symptoms. But in asymptomatic patients, I do not feel compelled to do radiation because the chemo usually works quite well.
How do you manage the patients who have previously received PCI and shortly after experienced brain relapse? Do you consider whole brain RT in that case?
Yeah, I mean, I would usually leave that to my radiation colleagues, but I will say that PCI is whole brain radiation. So it's not quite the same dose, right? But it is whole brain radiation. So in somebody with a short interval, it is hard to do whole brain radiation after they've had PCI. If there's a longer interval, a year, 2 years interval, then yes, I have seen radiation oncologists redo whole brain radiation. You really have to have a patient who's in good functional status in order to be able to do that, because it is sometimes challenging for them. But it is potentially doable. But the interval between the treatments is significant in order to be able to get away with that. Obviously, if they have focal, selective, limited metastases, then stereotactic radiation is something where there's an increasing amount of data on the benefits of stereotactic radiotherapy for the brain in small cell lung cancer.
What do you think about current second-line systemic therapies for advanced small cell lung cancer, which you prefer most and why?
Yeah, so in the United States, we have 3 drugs that are FDA approved at this point. We have topotecan, the old standard. We have lurbinectadine, newer chemotherapeutic agent, and we have tarlatumab, a BiTE or bispecific T-cell engager that's immunotherapeutic. We do not have any comparative data between those at this point in time. One study looking at lurbinectadine in combination with adriamycin compared to topotecan, they looked fairly similar. But how do we sequence those? We're really looking at mostly as single agents, cross-trial comparisons in order to try and figure that out. Because many of us have used topotecan for a long time, we've decided that it's not a terribly great option for these people. It has some benefit, 20% or so response rates, not very long duration of response. I think it's going to come down to hopefully doing comparative data, comparative trials, and looking at toxicities and your individual patient, what you think they might be able to tolerate best. The tarlatumab data is compelling. Response rates, about 40%, are similar to what we saw with lurbinectadine. Both of them look better with response rates than topotecan, but again, cross-trial comparisons. Toxicities of lurbinectadine, it is chemotherapy, so fatigue, counts become an issue. So most of us are using it and needing infusoport in order to give it because of toxicity on peripheral infusion. Tarlatumab is a bit of a challenge. I have only used tarlatumab in 3 patients thus far, so I do have personal limited experience. But we do have to admit patients to the hospital for the first 2 infusions or after the first 2 infusions for observation for 24 hours for cytokine release syndrome issues and for neurologic toxicity issues. I have seen both already in just the 3 patients that I've treated. So they all have their problems. The most compelling thing about tarlatumab at this point is the duration of response, that there is some group of people who are getting out much longer than we expect to see with relapsed small cell lung cancer. So hopefully that data will hold up and we'll continue to see these benefits longer term in people with the tarlatumab, the immunotherapy. But right now we don't know. I will tell you what I've been doing is I'm still using lurbinectadine as my second line treatment because I can get it going pretty quickly, and most people are in still relatively decent shape when they're getting it going. I will do that second line, and then get things prepared for the tarlatumab as third line. Is that right? Is that not right? I don't know. But that's the way I've been doing it thus far.
Thank you very much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.